What we will talk about, I promised that I would let you know there are other techniques other than anterior cervical discectomy fusion. When somebody's asked what are some of the controversies in what we do now in spine surgery, one of them revolves around when to do anterior surgery, when to do posterior surgery, or when to do both. Part of it has to do with what you like to do or what you are skilled at doing. So you can take the same pathology and have one surgeon like to work from the back of the neck and the other like to work from the front and have the same results. So that you want the surgeon to do what they're comfortable doing. There are fusion techniques and there are non-fusion or arthrodesis techniques. By far the most common, anterior cervical discectomy with fusion. Occasionally, including in Palm Beach County, but more often in Europe, you'll see anterior cervical discectomy without fusion, where just the fragment's removed, but as much of the intact disc is left in place as you can do. That was an older technique popularized 50 years ago. What they found 50 years ago is if you take the bulk of the disc out, the patient feels great, the disc space collapses, and you have a lot of neck pain. The patients that do best in that situation go on to fuse on their own, just by nature of two bones touching each other. But far and away, the ACDF is what you're going to see most often worldwide. Total disc replacement, TDR, first became approved maybe 5, 6 years ago, 7 years ago, and now there are a few cervical disc prostheses on the market. You'll see the occasional one go in here in Jupiter Gardens everywhere. And currently, at last check, the FDA has only approved us to put in a disc replacement at one level. But what we will see over the next few years is disc prostheses that can be put at 2 levels, or you can do a fusion at one level and a disc replacement at another, and that pendulum is swinging. So far, the outcomes have not seemed to be any different between a cervical fusion and a disc replacement. And if you use bad indications for the disc replacement, somebody that's got, say, facet disease in the back of the neck, and you replace the disc, it'd be like if you did a knee replacement on somebody where the back half of the knee was arthritic and you didn't touch it, you would expect they wouldn't do well. Well, if we replace the disc in the front and keep it moving, but the facet joints in the back were arthritic, all you're doing is inducing facet-related neck pain. So that's one of the contraindications to the procedure. Posterior laminoforaminotomy. That's a microsurgical nerve root decompression from behind the neck. That's our most fun operation, and we don't do it very often. You go from the back of the neck using a microscope or an endoscope. You find the bone spur that's hitting the nerve in the back of the neck, and you drill it away, and you're done. You don't do a fusion, you don't do anything else. And the fairly important indication for that procedure, a posterior laminoforaminotomy, if the patient tilts his head back and gets a painful paresthesia in a single nerve root pattern, and you see a bone spur on the CAT scan or MRI, it's a great operation because you don't have to worry about the fusion process. You're just taking away something that the person wasn't born with. But more often, the spur's in front, or more often there's a lot of neck pain, or more often the cord's involved, or they do this and they don't say anything. So there's a tight indication for that procedure, but when it's indicated, it's a great operation. Cervical laminectomy, posterior. That's the original spine operation 100 years ago, maybe 80 years ago. It's done less often now because it creates problems. The scar that forms where the lamina was can start to tether against the spinal cord as a person gets a little older and their neck goes from lordotic to kyphotic. So imagine if you have a thick rind of epidural scar left behind by removing the bone, and then the patient starts to get older, and their neck does this a little bit, which it does. Next thing you know, you're starting to pull that thick rind of scar tissue forward against the cord, and they get myelopathic. So, since we still had to keep operating, we've had to figure out, well, what can we do to not let that happen? So you do a fusion from behind. And I'll show you a slide of an x-ray where the laminectomy was done, but then screws are put in to stabilize the spine in the more lordotic position so it doesn't fall over into the kyphotic position. Microsurgical, minimally invasive, endoscopic, laser, reconstructive. That's what you put on your website to draw patients in. Interestingly, in preparing for this, I read one surgeon's comment, Dr. Rue. Dan Rue is like this, everybody that is in orthopedics or neurosurgery knows Dan Rue, like the most famous cervical spine surgery. Minimally invasive, maximally tissue destructive. So you can make this little teeny hole so that the patient thinks there's a small scar and that's all they can see. But then you can do whatever you want in there much more aggressively. You can macerate the muscle with the retractors holding things out. You're doing procedures with less valuable visualization. So instead of binocular or depth perception, if you're working through a scope, your visualization is not as good. So when those techniques are done by us, we have to be very cautious to realize we're working a little indirectly. Like patients over here, I might be working over here at the end of a TV camera. So there's more potential for error, so that the indications for surgery have to be really, really tight. That's an x-ray of the posterior cervical laminectomy and instrumentation and fusion in a patient who had most of the problem behind the spinal cord and also needed multiple levels operated on. And all in all, for that particular patient, it was a good choice. He did well. This is somebody we just did 1 week ago. Not quite the worst MRI you're going to see, but this shows a spinal cord which is compressed. You can see the vertebrae now that you've seen this. So just one more time to get your bearings. This is the back of the patient's head. There's the pelvis. I'm sure you all have that. That's the way we're looking at that picture. So you can see that there's a disc herniation at number 3-4, which is that big black structure that's long, and behind it you see a pointy facet joint and ligament combining like a pincher to compress the spinal cord. It's actually caused the spinal cord to turn white. That's myelomalacia. That's a scar that's forming, a loss of blood flow. If you had a stroke, that's what your brain looks like. You see the myelomalacia forming. So this patient came from the VA. So there was always a little delay going on there when they worked through that system. And he finally showed up, had surgery, and is going to improve, but he won't improve back to normal because you can't make that scar, damaged spinal cord go back to normal. You can hopefully keep it from getting worse, but this guy had already gotten a lot worse. So, all right, let's see what else we have. That's what it looks like on cross-section. That's a dramatic depiction of a large piece of disc in the spinal canal. That black structure over the light gray area is disc material. The spinal canal should be 2 times as big as it is. So he had a procedure, discectomy fusion from the front. He was actually scheduled and planned to do it from the back also if needed. But when we did the operation from the front, taking away the disc herniation and a little bone, we jacked the spine open a little bit. What that did in this patient's case was take that buckled ligamentum flavum, which is in the back of the spine, and pulled it a little tight. we hope, because we couldn't see it, but it did stretch the spine out. So we didn't then have to go to the back of the neck and do part 2. The complications from the posterior cervical spine surgery are a bit higher. The infection rate's about 4 times higher if we do an operation on the back of the neck. We almost never see infections in an anterior cervical approach. We see it commonly enough in the back of the neck. It's a different anatomy. The evaluation of patients, beyond what we've talked about, 66% of adults get neck pain at some point in their lifetime. Could be higher. There was an MRI study done 10 years ago now that looked at asymptomatic adults in the US, just walking by basically, and they funneled them into an MRI machine. They had to promise they'd never had neck pain ever, or arm pain. 20% of those adults on an MRI scan showed disc bulges, disc herniations, and degenerative changes. So when we see somebody like that in the office, we have to realize 1 in 5 patients might have something exactly like what we're seeing. So to clinically correlate what we're seeing on the MRI with talking to the patient and examining them is really what it's all about. Before you hear over and over again, we don't operate on an MRI. That's why, because you don't really know if what you're seeing on the MRI is causing a clinical problem. Most patients with neck pain get treated with therapy, get treated with time, rest, observation, and get better, or at least are helped. The patients that have a better improvement in neck pain with treatment are those that had some arm pain to go with it. It's counterintuitive. You'd think, well, they have neurological problems, but if they have a radicular arm pain and some axial neck pain, their chance of overall getting improvement is better than the chronic neck pain patient who comes in with an arthritic neck, whether or not, with no arm pain, they just have neck pain, they've had it for a while. Those patients are hard to make improve significantly. So you're coaxing them along with rehab techniques, and you don't see those patients very often in the operating room. When we're evaluating patients, nobody makes it to the operating room without having had an MRI. Most patients have also had x-rays. If a patient has spondylosis and stenosis, if they have bone spurs and narrowing, and if the MRI scan is blurry or poor quality, or they moved because they're claustrophobic, or they are in so much pain that the image is blurry, they might get a myelogram, old-fashioned injectable dye into the spine, followed by a CAT scan. In patients who have arm pain with extension and you're trying to do just a minimally invasive laminoforaminotomy, that's a nice test. An old myelogram CAT scan, which is done in the hospital, is very nice because it shows the spinal fluid and the nerve going through it and the bone around it more accurately even than an MRI. MRI doesn't show bone well. CAT scan shows bone well. So if you want to see bone, you get a CAT scan. If you want to see soft tissue, including spinal cord, you get an MRI. It's usually not that simple, so sometimes you can get both. CAT scans, I think as of this year, CAT scans are the designated first test over X-ray for a trauma patient. Any trauma nurses here right now? I think that changed this year. So you hit the door now in an ER, and instead of getting the trauma series, AP, lateral, obliques, they're just going to wheel you right into the CT scanner, which is right there in almost every emergency room, and in the same amount of time, but with a lot more radiation, have a much more accurate depiction of whether you have a fracture or instability from that trauma. And we all think that's a good thing that's happened. A lot of bad press about CT scan radiation exposure, which is a legitimate concern, but it doesn't seem to be much of a concern for the trauma patient